So let us talk about endoscopic management of diverticular bleeding and also look at other options for managing diverticular bleeding. So here we performed an endoscopy after stabilizing the patient, clearing the colon, and we notice some blood here close to a diverticular orifice. And let us learn about the diverticular bleeding. It presents as painless bleeding, and the bleeding could come from the dome of the diverticulum or from the neck of the diverticulum. So, figuring out whether it is from the dome or the neck is important because the type of therapy you're going to offer may change whether it is from the dome of the diverticulum or the neck of the diverticulum. So, diverticular bleeding can manifest in different forms. First of all, it is difficult to find the source of bleeding, especially in diverticular bleeding, because of the multiple diverticuli. Hence, it is important to use a cap-fitted endoscope. The cap would allow you to open the openings of diverticulum and peep in to find the source of the bleeding. And bleeding could be seen either as a clot or a visible vessel, or if you're lucky, you may find active bleeding. This is similar to what we see in peptic ulcer bleeding, a clot, a visible vessel, or an active bleeding. So when you notice bleeding, you have several different options that you could consider. One option is epinephrine injection. And when it comes to epinephrine injection, how do we go about delivering the epinephrine? Epinephrine injection is given in a dilution of 1 in 20,000. 1 to 2 ml are injected around the site of the bleeding and also in 4 quadrants that will create vasospasm of the vessel, uh, allow the clot to form, and stop the bleeding. When you give epinephrine injection, it is also important to add another therapy, either a thermal modality or a mechanical hemostasis. Otherwise, the risk of rebleeding is pretty high after just epinephrine injection without any additional therapy. So, the other options are you could consider bipolar electrocoagulation. And this is where it is important. You want to apply the bipolar coagulation if the bleeding is coming from the neck of the diverticulum. And you could use either a 7 or a 10 French probe, depending upon the size of the diverticulum and the size of the mouth of the diverticulum. And unlike peptic ulcer bleeding, where you use a different setting, for diverticular bleeding, you tend to use the lowest possible wattage, about 10 watts, and you don't apply firm pressure, a very little pressure, just a moderate pressure that would allow you to control the bleeding, and you apply the contact thermal coagulation at 1 second, that is short intervals. So a 7 or a 10 French, 10 watts, 1 second intervals. So how about if we want to do a bipolar coagulation and you notice that the site of bleeding is not the neck, where you have the muscle behind the neck, but it is in the dome of the diverticulum, where you have nothing behind the dome. In that case, make sure that you do not use electrocoagulation because you don't have anything to back up and you are at risk of creating a perforation. So finding where the bleeding is coming from, if it is in the dome, no cautery. Now let us look at mechanical hemostasis using a clip. And when it comes to clip application, you could apply the clip without worrying about damage because clips do not create any thermal damage. And you could apply the clip directly to the bleeding site and deploy the clip that will control the bleeding. Or you could also use the technique of what the surgeons use by going after the feeding vessel and controlling the bleed. Sometimes if the opening of the diverticulum is small and the diverticulum depth is also shallow, in those cases you could consider the option of closing the opening of the diverticulum, and that itself will create pressure if it were to bleed and stop the bleeding. So closing the opening is another option. So when it comes to clip application, direct application on the bleeding site or on the feeding vessel or closing the mouth of the diverticulum. Recently, Dr. Johnson and his colleagues have shown that you could use a Doppler probe to see whether you have occluded the vessel, and if there's no Doppler, those patients are less likely to rebleed. Another option that has been suggested is the role of band ligation. So, to put a band after you found the diverticulum that is bleeding, you have to take the endoscope out. So, you have to take the endoscope out, you have to use a gastroscope, load the band ligator, and then come back to find this source of bleeding. And you may not find that source of bleeding. Hence, it is important to place a tattoo to mark the site of the bleeding. And once you have a tattoo, you can come back with the band ligator applied to a gastroscope or a PD colonoscope. And then you apply the band similar to the way we apply a band for ligating varices. And the diverticulum will evert and the band is going to occlude the feeding vessel. So we have several different options. Epinephrine injection for hemostasis, a bipolar electrocautery with the coagulation mode, clip application, band ligation application. So if the patient is actively bleeding and you control the bleed, but it's also a good idea to, before you come out, you put a tattoo at the site of the bleeding, at the site of the diverticular bleeding. And why is that? If the patient rebleeds, you can go back and try to apply additional endoscopic therapy. Or if the patient is rebleeding massively and you cannot go back, and if the patient needs surgery, uh, then the surgeon can find that site very easily. So that's the benefit of applying a tattoo at the site of a diverticular bleeding after you have controlled the bleeding. I also suggest that apply a clip on a fold very close to the site of bleeding, and that clip will help navigate the interventional radiologist to the site of the bleeding, and he can super selectively uh, get to that vessel that's bleeding and apply coils there without damaging too much of the colon. So this is After you've applied endoscopic therapy, before you come out, place a tattoo and also place a clip. That is for surgeon and intervention radiologist if the patient were to bleed again. How about patients that are bleeding massively? That means the patient comes in with severe bleed, hypertension, and you're trying to resuscitate. You have already given 3 units of blood. The hemoglobin has not budged. That means the patient is having ongoing active bleeding, and in that case, you could go for angiogram. All right. And when it comes to angiogram, uh, if you use superselective uh, cannulation of those feeding vessels, you could deploy some coils and embolize. In some cases where the patient has bled and whatever options you consider, it did not work, but you know the source of the bleeding, and you have marked the source of the bleeding, then surgery could be an option. And having the source defined, the outcomes of surgery are going to be good. If you don't have the source defined and the surgeon goes and does a blind resection, the outcomes are not as good because those patients are likely to rebleed at a much higher rate. So, in this case, we have identified the source, we have put a tattoo, and send them for resection and anastomosis. So, we talked about different options for managing diverticular bleeding, and if the patient is not suitable for endoscopic intervention, somebody who is massively exsanguinating, one should go for IR and embolization. As part of the IR embolization, it is also important to consider the role of CT angiogram that might help the intervention radiologist find the site. If the patient is bleeding intermittently, then there is a role for RBC scan. So we have covered a lot of material in the management of diverticular bleeding. I hope this is useful. Thank you.